Now, this event really follows on from our recent event, Rare Disease Genomic Testing. How do we make access equitable and timely? And so today we're really focusing on a particular group of rare diseases. All of us who live, breathe, eat, and think are able to do so thanks to our metabolism, the set of chemical reactions via which substances are transformed inside our bodies in order to sustain the functioning of our cells, tissues, organs, and systems. Our metabolism enables us to obtain usable energy from the food we eat and then get rid of the toxins that are left over. All of this, in turn, is dependent on our DNA, which tells our body how to manufacture the molecules that make metabolism possible. There are a vast range of diseases that can disrupt human metabolism, and thousands of these diseases can be inherited. Such metabolic diseases are rare in the sense that the precise cause and consequences of each disease occurs in a relatively small number of people. However, when you add all those people together, collectively, inherited metabolic diseases are actually common. And now many inherited metabolic diseases affect the central nervous system. Um, but such diseases can potentially affect any of our bodily systems, and the impact of such diseases on children, adults, and families can be devastating. Now, we have a fabulous panel of experts and advocates for you this evening, including the pioneers of relevant medications and of a gene therapy that involves genome editing. And their presentations will cover diagnosis, treatment, support, and broader public understanding. Jonathan is lead for campaigns and communications at the charity Metabolic Support UK. He is a member of the Patient Organisation Steering Committee of the ABPI, the Association of the British Pharmaceutical Industry. Previously, Jonathan was a medical lab assistant at Liverpool Clinical Laboratories.
Metabolic Support UK is a charity. We were established in 1981. We support just under 2,000 rare conditions and 40 plus thousand people worldwide. We have a multidisciplinary team consisting of insights, advocacy, individual support, communities, campaigns, and comms. Our team includes a health economist and postdoctoral researcher from the University of Cambridge, and they work to drive evidence for policy. We have an individual support team with over 23 years of experience who tailor person-centered help. We have an award-winning campaigns and comms team working across the UK and internationally, and our CEO, Kirsty Hoyle, is a leading disability rights background, and she has strategic leadership. We also active in some national and international networks. So, for example, the Metabolic Clinical Reference Network, the newborn screening groups for tyrosinemia type 1's rollout, some medicines advisory boards and rare disease collaborative networks, such as the Adult Rare Bone Disease Network. So what are IMDs? This has already been touched on a little bit by Sarah, but there's just under 2,000 rare genetic conditions, and these disrupt the body's metabolic processes. For those of you who weren't really too sure what they were, if you've got a child, it's likely that they have been tested for them in the newborn screening panel because previously it was 6 conditions included on the newborn screening panel for England, and now that is 7, including uh, including tyrosinemia type 1. But symptoms can occur at birth or later on in life, and they can be life-altering or life-threatening. And symptoms and management and outcomes can vary significantly. So, just to give you a bit of insight into the kind of broad range of how they can present. So, for example, TMAU, this results in the impaired breakdown of trimethylene, causing odor symptoms. And this is often diagnosed late after significant psychosocial impact because if of it's an odor causing condition, people don't really know too much about it, so they can be shunned and they can face significant sort of discrimination as well. And if people don't know about it, they don't know how to manage it too. That is mainly managed through diet and lifestyle with limited specialist support. Whereas you've got conditions as well, so OTC deficiency, and this is a urea cycle disorder, affects how the ammonia is processed in the body. This is different in the fact that it's not like with the like sort of odor causing symptoms. It's an acute, often life-threatening symptoms that come on with that, and it requires emergency management, dietary restriction, and specialized hospital care. But due to the lack of awareness about these conditions, the ammonia test isn't actually conducted a lot of the time, and it's often misdiagnosed as things like sepsis and meningitis, which then delays the results, and then that then leads to worsened outcomes and potentially even death. So that is what our Think Ammonia campaign is about. It's about raising awareness about urea cycle disorders so that people are saved. So what we do, so individual support, we provide tailored individual support to our communities. We have had 242 inquiries in the last quarter from 29 countries, and this is a growth of over 25% from 23 to 24 and over 34% from last year. We help in a wide variety of areas. So obviously, because there's a lack of awareness about these conditions, people really struggle to access benefits that they need. And because of this, we have to support them with that. So it's really difficult for people to stay in work because they've got things like fatigue, pain, they have to manage a strict diet and have frequent appointments. So it's really hard to maintain a job and stay in that situation. So we can help them to get access to that PIP support. So our individual support team work with them directly to actually support them there. Access to reasonable adjustments. Once again, because of the lack of awareness about these conditions, we've had situations where people have been called lazy because they've got fatigue due to their condition. So we have actively worked with specific employers to advocate for our communities and to ensure that they have the reasonable adjustments that they need to be able to actually access work as they have a right to do. And then healthcare navigation. It's so difficult for people to navigate the healthcare system, particularly in adult care as well. Even if you do have a diagnosis, often the care is quite disparate. It's quite hard to engage with different services, and people often have to manage that care themselves. So we help there as well. We support people, we provide resources, and we help them to access the professionals that they need to. And our campaigns, we run both targeted and cross-cutting campaigns that are data-driven and underpinned by lived experience of our communities. So the Think Ammonia campaign is quite a targeted campaign. Well, as I've just mentioned, it's to improve outcomes for people experiencing hyperammonemia, and we are doing that in collaboration with healthcare professionals, with our communities, and with other stakeholders to actually raise awareness in the healthcare professionals, and also to advocate internationally as well. We've got the Live and Well movement, which is more cross-cutting, and this is embedding how our communities live well in society, law, and policy. We want our communities to define what living well means to them through community voice, to improve understanding, and to integrate that into the Equality Act 2010. And both targeted and cross-cutting campaigns are essential to drive change. Insight and advocacy. So this turns lived experience into actionable evidence and data, improves access, and ensures policy is reflective of the community need. So, for example, we support HTAs. So, a recent example would be that we partnered with the Cystinosis Foundation and Kidney Research UK, provided evidence to the Scottish Medicines Consortium with patient group submissions spanning 8 years with 4 submissions. And we showed that the delayed response improved quality of life, sleep, breath, odor, and that actually resulted in that treatments being approved for treatment for nephropathic cystinosis in Scotland. And the SMC actually referenced the patient group input in the press release as a key factor. We also influence policy, so we input into things like the England Rare Disease Action Plan consultations. We share our findings on the wider determinants of quality of life, and this was referenced in the 2024 Action Plan. And we also share briefings with SHCA and rare disease ministers about the importance of recognising the needs of our communities. We also lead research on clinical trials, so we will lead on patient engagement strategies with industry and research teams. We support the design, language, recruitment and training for research readiness. And we are also exploring things such as a patient-reported outcome specifically to inherited metabolic disorders, so those measures are representative of our communities. So I am the community experience and healthcare. So this can really differ. So, access and experience, so awareness and navigation, there is a real limited knowledge of referral routes, delays in diagnosis, and this can lead to missed or inappropriate referrals. System follow-up gaps. Patients, even with a confirmed diagnosis, often have to find ongoing care themselves, and then regional inequalities. Specialist IMD services are concentrated in major cities, so people have long travel times and limited adult pathways. So, for example, for people based in Cornwall, they might have to travel to London for an appointment, and that really puts pressure on people. Capacity in workforce, there's a small, highly committed teams, but they are under a really great amount of pressure with little succession planning. So people are having to delay their retirements, or there may be limited resource for service expansion, which then impacts on our communities, of course. And then there's pathways and funding. So it's unclear or inconsistent care pathways, especially for things like carbohydrate disorders. People can be referred onto gastroenterology for investigation when actually they should be referred onto a metabolic team. There's also confusion over responsibility, over funding on out of area referrals as well. And families have actually described feeling broken and defeated before diagnosis, desperate for information about their child's illness, and often only receive 2 pages of printed from the internet as guidance. So, thoughts into action. So, understanding quality of life in IMD. So, we conducted a research project back in 2023. This spanned 57 individuals and families to define quality of life from the IMD's community perspective. We identified a net of factors that sustain well-being. These range from identity, employment, benefits, food, healthcare, transitions, and mental health, with gaps in these areas leading to people falling through the net and resulting in a reduced quality of life. But there is opportunities to really shape the future and improve outcomes for our community. So, for example, the generation study. So, whole genome sequencing could enable faster, more accurate, and targeted treatment for a wide variety of conditions. Around half of the conditions included on the generation study screener panel are IMDs, and we have worked closely with Genomics England on developing patient-facing materials and also reviewing things that they have. We've also released training on our website so our community can engage with that study and really expand that knowledge around it. Expanded newborn screening, so early detection of IMDs, of course, prevents complications and can support timely intervention. We have obviously been involved in the rollout of tyrosinemia type 1, which is now released in England, and that will now be released in the devolved nations in the coming year. We will continue to work with the UK NSC to expand the panel. So the policy change, we need a shift from healthcare focus to address the wider determinants of quality of life identified through our thought to action research to improve outcomes. We are actively responding to consultations and engaging with policymakers to ensure this is realised by our communities. So our work in pictures, I just wanted to include this at the very end to kind of give you a visual representation of some of the work that we've done. So this really ranges from bringing communities together to engaging in the MHRA, to sharing research posters and to the generation study, to attending parliamentary events, and just basically making sure that our communities are supported and that they are advocated for at the highest level. If you have questions, of course, we've got the Q&A session, but if there's anything you think of afterwards, feel free to just get in touch with there. So we've got our CEO, Kirsty Hoyle, myself, I'm the campaigns and communications lead, and then we've got Laura Smith Van Carroll, who is our head of insight and advocacy.
So our next speaker this evening is Dr. Srividya Srikantam.
How can we improve the quality of life? One way is timely recognition and early management and to improve the outcomes. So I'm going to focus on recognizing the red flags in clinical presentation of metabolic disorders. So what are metabolic disorders? Sarah just mentioned very rightly that they are not uncommon. They are rare, but not very uncommon. They happen due to changes in the genetic code or faulty genes which are passed on to the next generation from parents. And they're more common in families where there is more cousin marriages being prevalent. So there are many disorders. So they can happen in the protein pathway or the fat breakdown pathway, the carbohydrate pathway, or coming to the mitochondrial disorders, which produce energy in every part of our body, the cells. And there are various other organelle disorders. The lysosomes are involved in recycling. So if there's any problem, it results in a lysosomal storage disorder. So, we don't realize our body is like a factory. And exactly as Sarah was mentioning, thanks to our metabolism, we are able to create energy, break chemicals, make chemicals. And this slide definitely makes us feel, oh my God, the metabolic disorders are quite complex. But there is a simplified approach to understand what happens in a metabolic disorder. So with the help of a genetic code, an enzyme is made. And with the help of another cofactor, both the enzyme and the cofactor, which is usually a vitamin, we are breaking the substrate to produce a product. And because of a genetic faulty, gene, the enzyme is deficient or a vitamin is not working properly, and then this results in a substrate getting accumulated. So there's more chemicals being stored, and there is product deficiency, both of which lead to a metabolic disease. Let's look at an example to understand this. So we have a glycogen breakdown in the liver. We all need to do this to help us cope with fasting. And for any enzyme deficiency reason, this doesn't happen. The glycogen gets built up. And when it gets built up, babies present with a distended abdomen, and they can't break down glycogen to produce glucose. So they have a low blood sugar and can present with symptoms related to low blood sugar like seizures, or older children can be a bit sweaty, clammy, and complain of headache. And the same storage, if it happens in a muscle, it can cause muscle weakness. It's not working properly because there's no energy. So Pompe disease is one such example where the glycogen gets stored in lysosomes, and it is a treatable condition. That's why it is important to recognize. So babies can present in a severe way. They can be quite floppy, as you can see in this picture. They can have a weak heart muscle, or their breathing muscles are not very strong. So they might depend on a ventilator or, some sort of breathing equipment. And you can see slightly older child, a young man here, he's struggling to get up from the floor due to proximal muscle weakness. And slightly old age, they can present with just facial muscle weakness. Why is there a difference? So babies present quite severely, and a young man is struggling a bit, and the slightly older age group, they're okay. And this is to do with the amount of enzyme which is missing. So if we have hardly any enzyme activity, babies present quite severe because they don't have any enzyme activity at all. Whereas an adult or a child can have a little bit of enzyme, enough to break down glycogen. So they present with less severe symptoms and at an older age. And how do they present? What are the red flags which I've been talking about? And it's important to recognize these. So, the red flags can be present right from pregnancy. So we discussed how it is more common in cousin families. So it's important to ask for history of consanguinity. So the mother might be having something called a HELP syndrome, where the liver enzymes are elevated and then this platelet count is less, or we can have some abnormalities in the antenatal scans. We discussed how muscle disease can affect the movement. So the baby might not be moving very well in the uterus, or on the other hand, moving a lot, which the mother thinks, oh, my baby's quite active, but actually is having in utero fits, hiccups, a very strong red flag for metabolic disorder. These need definitely metabolic investigations. A classic picture, not present in every case, is a symptom-free interval, because thanks to the placenta acts as an in utero metabolizer. So the baby is fully dependent on placenta. After birth, there's no placenta. So the baby now has to deal with the metabolism. And if there's any enzyme deficiency, will present with symptoms. And these can be like sepsis-like picture, or sudden collapse, or have very high levels of acid levels in the blood. And this is seen as, abnormal blood gas when doctors take the test. And because of the chemicals, they can be a little bit have unusual smelly, like maple syrup urine disease. They can be very drowsy. It's very difficult for first-time mothers to pick up that clue. They can just get worse and become comatose and die. The liver is an important organ metabolizing many stuff. So this might not be working very well if there is a metabolic condition. And enlarged organs, as we've seen in that picture, because organs are, storing chemicals, and babies are presenting with big liver and spleen. Or multi-drug resistant fits, an important symptom again to look into. Later on in childhood or infancy, they can be very delayed or regress or loss of skills, a very important red flag for metabolic disorders, or have coarse facial features. Now, what are coarse facial features due to? This is because of storage of chemicals in the face, storage of chemicals in the tongue. You can see this boy has got a very big tongue, and that can also have implications because it's getting, airway, impinging with the airway block. They can have cyclical vomiting. Now, these children need investigations. They can have the abnormal chemicals getting accumulated whenever the child is unwell, resulting in episodic confusion and cyclical vomiting. They can have fasting intolerance or, myopathy or cardiomyopathy or various eye abnormalities, which I'll show in pictures later. So this is the hazy cornea in a condition called mucopolysaccharidosis. Now, in this condition, the mucopolysaccharides or the chemicals are not recycled well in the lysosomes. As a result, they can affect all organs. So you can see the cornea is very hazy, almost like, the car, front screen is not very clear. The chemicals can get stored, resulting in an umbilical hernia. And again, this child, the airway is problematic because of the chemical storage. You can see claw hands. And even in the brain, there is storage compressing the spinal cord. So they do cause multiple, multi-system involvement. Sadly, these children go to one specialist and different specialists, but unless somebody does the testing for this condition, they can be missed. There's enzyme replacement therapy for this condition. So it's important to investigate for this. And some more examples. This little boy has got severe alopecia. You can see loss of hair. So previously he wasn't like that. And this condition is called biotinidase deficiency, where they can present with severe alopecia or loss of hair and eczema, and they can regress. It's important to diagnose this condition because it's treatable with the vitamin biotin. This is the cherry red spot, which I was mentioning in the previous slide. So the lysosomal storage disorders can cause this picture when somebody is looking at the back of the eye. So the fat cells are stored in the retina, causing the pale color. The red spot is actually the healthy retina. This boy has homocystinuria, now is included in the newborn screening for a while. So the homocysteine is not broken down, gets accumulated, causing learning difficulties, lens dislocation in the eye, and bone problems. It's important again because it's treatable with diet and vitamins. This boy has got Menkes disease, which is to do with copper metabolism. This is called Menkes kinky hair syndrome. They have intractable seizures and can be treatable initially to certain extent if diagnosed antenatally and the copper treatment is started within the first 1 month of life. So the important main message is that we have to diagnose early. Timely recognition is important. Let us see how adolescents can present with metabolic red. What are the red flags? Myoglobinuria. So myoglobin is a pigment. Muscle protein can break down, causing cocoa-colored urine after a prolonged exertion like marathon. So if that happens, or on an exercise or illness, that needs investigation. That can happen in other disorders, but a red flag for metabolic disorders too. Stroke-like episodes, behavioral problems, or any gait disorder, walking abnormalities need looking into. Abnormal chemicals can irritate the pancreas and cause pancreatitis. So, and any unexplained liver or heart problem, think of a metabolic disorder. Do I need to do the testing? Now, what sort of testing is available? We talked about chemicals. So we can certainly, our first line test is blood and urine chemical testing. And then there is enzyme testing. So whatever enzyme is missing, we can get an enzyme assay to check the levels. Genetic code interpretation, genetic testing. We can read the genetic code for the child and the parents. And when I say we, it is a genetic team, not me. Newborn screening. Now, Jonathan was mentioning how the 7th condition got included recently, tyrosinemia type 1. And genome testing. So we are now screening for more than around 200 genes in newborn blood spots. So this is all about testing. And once we get the testing, this is information-wise, there's loads of information on patient support organization groups. There's MSUK, AGST, LXTLC, MPS Society, loads, and PET. Temple guides and BIMDG guidelines. There are lots of information for professionals as well for the BIMDG guidelines. Coming to the treatment, I won't go much into the treatment, mainly because there's Prof. Platt and Dr. Julien are going to cover this in a bit more detail. But coming back to our, the principal reaction, the enzyme breaking down the substrate to product. So if it is a protein breakdown problem, so the children are put on and the adults are put on protein restricted diet because they can't break down protein, or a fat restricted diet if they can't break down fats. Enzyme replacement therapy. So there are ways of giving it. We either give it as a drip, or we can give it into the space around the brain and spinal cord called the intrathecal enzyme replacement therapy. Substrate reduction therapy, where it's almost like the sink is blocked and we are trying to, switch off the tap, and which is giving medications to stop the substrate being built up. And bone marrow transplantation and genomic editing and gene therapy, which Dr. Julien and Prof. Platt will cover in their talk. So just want to quickly take you through a case to emphasize the importance of timely recognition. This is one of our patients, twin 2, who presented with delayed motor milestones. And initially that was attributed to, could she be having a problem with hip, because she was having lots of ultrasound scans for clicky hips. And so developmental dysplasia of hip was the, thought process for that. But then, and she was also commando crawling like an army soldier. So at 3 years of age, she started having a bit of an unsteady gait, and she lost her fine motor skills. And we just discussed how regression is an important sign and it needs investigation. She also had muscle stiffness at the ankles. I'll just show her video. This is her, a patient at 3 years of age. I got consent for this videos. So you can see she's unsteady, needing support, and almost lifting her leg and moving forward. This is called a high stepping gait seen in neuropathy. She had her diagnosis made on a neuropathy gene panel analysis, which showed that she's got a really horrible condition, metachromatic leukodystrophy, affecting the white matter of the brain. This is sadly regressive, and there is gene therapy for this condition if we pick up at early symptomatic stage or pre-symptomatic stage. Now we see that our little friend is already quite symptomatic in this video. So she sadly didn't qualify for the gene therapy. And we started intrathecal enzyme replacement therapy delivered into the, space around the brain and spinal cord. So this is her about 1.5, 2 years after the therapy. You can see that the intrathecal therapy has slowed down the progression, but didn't really halt it. So she continued to lose her skills, sadly, afterwards. But she enjoyed the quality of life a little longer than what would have been a natural course of the metachromatic leukodystrophy. That's her twin, and who is being tested and found to be unaffected. And that's the advantage of diagnosing in a, when I say early testing in a patient, that will help test the pre-symptomatic sibling. Sibling can have the test before symptoms and maybe qualify for gene therapy. So the main take-home message to improve the outcomes in metabolic disorders is timely recognition and early management, that to ensure that we're really giving the best possible quality of life to these patients. It is also important not to miss a treatable disorder, something like biotinidase deficiency. Or there are many other treatable conditions. It's important to understand and do early testing. So if the patient is too late for gene therapy, at least sibling would benefit from undertaking and recognizing the disease. Genetic counseling is important for future pregnancies, and that can help the future generation, at least if you're not able to help this patient. So with this, I would like to end my talk, and massive thanks to PET, Sarah, Annalise, and all other PET members, and Sandy for, and patients and families, all patient support organizations, and IMD team members, some of whom are in the audience, and all other speakers who have joined to raise awareness for rare diseases to improve outcomes.
Following on now from video, we have our next panelist, who is her colleague at Birmingham Women's and Children's Hospital, NHS Trust. So we have Professor Evangeline Wassmer. Evangeline is a consultant in paediatric neurology, and she has led the neuroimmunology and neurometabolic disorders services in Birmingham for more than 20 years. She is an honorary professor of paediatric neurology at Aston University's School of Biosciences, and she has worked with national and international research groups to establish the phenotype and define the clinical course of several rare metabolic diseases, enabling earlier diagnosis and treatment.
So besides the exciting new treatments from which you will hear later, like gene therapy and stem cell therapies, there are specific metabolic treatments like diets, replacements of deficiencies, and scavengers for toxicities. However, many children still require daily symptom management to ensure life is comfortable and good. Children with inborn errors of metabolism have a range of symptoms and needs, and we provide care and treatments from drugs to therapies to surgeries. The aim of these treatments is not only to improve specific symptoms and modify the disease course, but also to improve comfort, function, participation, and well-being. Although these interventions are standard practice, evidence regarding efficacy and safety is limited. It's essential, however, to have this evidence. The symptoms range is wide and that we see in our daily practice. And I've highlighted some of these because as a neurologist, these are the ones that I often have to deal with. If we look at motor difficulties, children experience a range of motor difficulties from the unsteady gait to severe stiffness and movement disorders. There are many interventions that we try and that we have experience with for these motor difficulties. The evidence, however, is a little bit sparse. Even if you look at the NICE spasticity guideline, they highlight that they are unable to provide guidance on timing or the intensity on any of these interventions. Only medication like diazepam and baclofen have some evidence. The more intense interventions like the baclofen pump and deep brain stimulation have better evidence, but we have a lot still to learn. Epilepsy has more evidence, but this is not specific to rare metabolic disorders. Our experience shows that we try to use drugs which are clean, like levetiracetam. These are not metabolized by the liver. We also avoid certain drugs in certain metabolic disorders. For example, we don't like to use sodium valproate in children with mitochondrial disorders, or we avoid levetiracetam in children with non-ketotic hyperglycemia. Behavior is a challenge, and although I'm a neurologist, we do deal with behavioral difficulties too. The mental health services in the UK are stretched with long waiting times, and often these professionals are uncomfortable or worried about treating these children with rare metabolic disorders, as they know so little about these conditions. The range of symptoms that these children have is broad. It ranges from ADHD and autistic traits to low mood, compulsive disorders, anxiety, irritability, agitation, psychosis, and even the most awful symptom I find is the self-mutilation. We treat these children with a range of medications, including antipsychotics, benzodiazepines, antihistamines, antidepressants, and even sodium valproate. We also use therapies like cognitive behavioral therapy, sensory integration therapy, and talk therapy. The evidence for metabolic disorders is limited, but we know from experience that, for example, certain drugs you have to use at low dose. Antipsychotics are not well tolerated. The children often have many side effects, and therefore we would use these drugs rarely and at low dose. Sleep is something we all need, and yet this can be a real burden for children with inborn errors of metabolism. We start off usually by taking a good sleep history, sometimes followed with some sleep studies. Then sleep hygiene, advice to ensure that the children have healthy sleep habits. And then there's a list of medications to consider. Unfortunately, all of them with very little evidence, and yet we have vast experience in using them. So in summary, there are many challenges with symptom management. Optimum management is rare. The symptoms interact, and we really still don't know enough about many of the treatments that we use. So here's a challenge for you. We really need to collect evidence so that we can manage the symptoms better, understanding the efficacy and safety, but also to answer questions of when to treat, who to treat, and how long do we treat.
Our next speaker this evening is Professor Frances Platt, who is a pioneer of treatments for metabolic diseases, in particular lysosomal storage diseases. Her research has led to the development and approval of medications to treat these diseases. Frances is a professor of biochemistry and pharmacology and head of the Department of Pharmacology at the University of Oxford. She is a trustee at the charity Nieman-Pick UK and contributor to books including Lysosomal Storage Disorders, Gaucher Disease, and Immunosugars.
So I wanted to just share with you some progress that is being made in sort of small molecule development for lysosomal storage diseases. And Srividya has done a really nice introduction to lysosomal disorders. I just wanted to start with a disclosure that I'm an academic co-founder of IntraBio that relates to one of the drugs. And also we conducted preclinical studies with Orphazyme on one of the other drugs that I'll be mentioning. So lysosomal storage diseases are a group of about 70 plus disorders that collectively affect about 1 in 5,000 live births. And this schematic diagram is just to illustrate the fact that of the 60 or so genes that are involved in causing these diseases, they affect different organs of the body because all of the different cells have lysosomes that are our recycling and waste disposal units of the cell. And so when we're thinking about trying to treat these disorders, we may have very often neurodegeneration as one of the phenotypes, so the nervous system can be involved. It's very common for the liver and spleen to be enlarged. You can have problems with blood cells. You can have problems with muscle, as we've heard in things like Pompe disease. And so one of the questions is, are there mechanisms through which we can try and treat these diseases at the whole body level? Because these disorders don't just present in one organ of the body. And this is quite a challenge. And what we've seen over the years is remarkable translation in the space of rare lysosomal storage diseases. And the pioneering work was done with enzyme replacement therapies. These are intravenous infusions or direct to the brain, as we've heard in, for example, one of the Batten diseases. And the issue with this is that the recombinant enzyme, if it's an enzyme deficiency that's causing the disease, has to be given intravenously very regularly. This can be a transformative therapy, but it does require invasive administration, often in a clinical setting. There's also been remarkable advances in gene therapy and gene editing that I'm sure we'll be hearing about. And these, again, are biologic therapies. They are not small molecule based. And because enzyme replacement therapies started in the 90s for lysosomal diseases, they've been really transformative, and we're on the cusp of a major expansion in gene therapy and gene editing for these disorders. But the question is there a place for small molecules that are modulating the disease process? And we've heard about one of those already today, which is substrate reduction therapy. This is the sort of turning off the tap in the blocked sink, nice analogy, reducing the number of molecules that the lysosome's having to break down, and this can counteract an impairment in degradation of these molecules. Another approach that has been so far approved in 2 diseases is an enzyme enhancement or a chaperone-based therapy. And the idea here is that you use a small molecule to make the enzyme work a little bit better, fold into a more active conformation, and this has made progress in certain diseases. And then more recently, we've been working on what we're calling a metabolic modifier therapy, which is sort of redressing imbalances in energy metabolism downstream of the primary product. We saw that really complicated schematic of metabolism. And what happens in these diseases is even though there's a single gene and a single protein that goes wrong, there's collateral damage into this very interconnected set of pathways. It's a bit like disrupting the tube, the London Underground, that if you had a power outage at a major hub on that network, it can have knock-on effects elsewhere. And so what these therapies are doing is really dealing with the downstream problems in the disease. They're not treating or correcting the gene. They're not replacing the faulty protein. But what they're doing is modulating those complex pathways to try and reset balance back in the system. And that's really what I wanted to talk about briefly today. And one lysosomal storage disease that we've worked on a lot over the years is a disease called Niemann-Pick type C. And I'm presenting this particular disease because all 3 of those small molecule approaches are now approved in this single disorder. And so I want to talk to you a little bit about the opportunities, but also the challenges of having multiple small molecules available for the same disease. So Niemann-Pick type C affects about 1 in 100,000 live births. It's caused by mutations in either of 2 genes called NPC1 or 2. And on the right, there's a picture of the lysosome just showing you the proteins that are encoded by these genes that can be faulty. And the NPC1 protein sits in the limiting membrane of the lysosome, and the NPC2 protein is a soluble protein in the lysosome. And they work cooperatively to help lipids move out of the lysosome to other parts of the cell. And it has a bewildering array of lipids that are accumulated in this disorder, ranging from LDL-derived cholesterol through to sphingolipids. And there's also a block in the trafficking and the movement of lipids in the cell, and there's a problem fusing the lysosome with other compartments. So a very complicated biochemical and cell biological picture. But it turns out that this complexity actually provides a goldmine of possible ways of intervening with small molecule drugs. And the translational advances in this field really started back in about 2009 with the approval of the first drug for this disease. And very interestingly, we've had nothing since 2009. And then just like buses all arriving at once, we had 2 FDA approvals in the space of a week in September of last year. So I just wanted to, in this table, really just summarize where we are with NPC therapeutics. They are actually all small molecules currently, which is unusual for a lysosomal storage disease. Miglustat was the first to be approved, which is a substrate reduction therapy drug. It's given orally and is the standard of care that's been used for many years. And it was approved in Europe in 2009. It's never been FDA approved, but many American patients are on this drug through their insurance companies. There have been some trials of cyclodextrin, which have not yet reached approval. One was intrathecal, and that's now ceased, but the other is an intravenous approach, and that is currently in progress. But the two recent approvals are two drugs. One's called arimoclomol. It's a protein that helps the lysosome to function better. It activates proteins called HSP70. And this was approved because it was shown to have benefit in mouse models of Niemann-Pick C and also in a placebo-controlled clinical trial. And then the second drug that was approved in the same week last year is a drug called acetyleucine. It's a modified amino acid. And this is the drug that's a sort of metabolic enhancer. This one's called Acnersa. And there is a decision pending at the moment by the EMA. Now, if we look at what miglustat does to, after 10 years of experience it's now a generic drug. Its patent period has expired, and it's allowed the collection of 10 years of experience with this drug. And this graph is just showing you that in the pre-miglustat era, the average life expectancy, or the probability of survival of patients untreated, was about 11 years. And that's been pushed out to 22 years by miglustat. And so what we've been interested in this field is whether or not we can add other small molecules in combination with miglustat to tackle the disease through other pathways that are perturbed. Because at least in animal models, when we do that, we see synergistic or additive benefits. So we're very much wanting to move into a combination therapy era. Now, arimoclomol, the drug that improves the NPC mouse model and was beneficial in clinical trials, has an interesting mechanism of action, because one of the main things that it does in the mice is that it improves myelination in the central nervous system. This is an undermyelinating disease, and it's because the specialized cells that form myelin in the brain, oligodendrocytes, don't differentiate properly, and so you undermyelinate. And there was really beautiful rescue of that in the mouse model. And this mechanism, we don't yet know which stage of disease this will be maximally beneficial in NPC patients. But following the approval of the drug, obviously those data will be collected moving forward. Now, the second recently approved small molecule is acetyleucine, and this drug improves symptoms of cerebellar ataxia. I should have mentioned that this disease has cerebellar ataxia as a prominent clinical sign, and it's also one of the childhood dementias. So there's also fine motor skills and cognitive decline in these patients as well. And in a double-blind placebo-controlled trial that was published last year in the New England Journal, we were able to show that the patients improved in terms of their, on the SARA scale of assessing ataxia, and then they would relapse when they were on the placebo arm. And this was a crossover study, so each patient was also acting as their own control. And based on the two clinical trials having positive data, the FDA approved both of these drugs last year. So all three of these Niemann-Pick C drugs have potential utility in multiple diseases. So whereas an enzyme replacement therapy, you need to make a recombinant enzyme that is specific to the enzyme deficiency. If it's a lysosomal enzyme that's defective, all three of these drugs have what's called platform capability, and that is that they can show utility in more than one disease. And so this means that there's a lot of ongoing studies, for example, in whether miglustat would be beneficial, for example, in the Batten disease, group of lysosomal storage disorders. In addition, the MIPLEFA, that is this HSP70 activator, has shown in other model systems and in multiple cell lines from different lysosomal diseases to also have benefit. And ACNURSA, which restores sort of mitochondrial and lysosomal function through this metabolic rebalancing mechanism, has also shown in model systems and mouse models, for example, that it may show utility in other diseases, both lysosomal storage diseases and potentially more common neurodegenerative diseases. And the reason I'm belaboring this point is that all three of these drugs are acting on different defects, collateral damage that happens downstream of the genetic problem. And in animal models, we've seen really good synergy between some of these different combinations. And so the field now has a sort of a wealth of riches of small molecules, which brings a really good problem to have, which would be good to have in many, many more metabolic diseases. And that's, how do you work out how to optimally use three small molecules in a single disease in real world clinical practice? And one of the really key points is that we're very, very fortunate in the Niemann-Pick world, in that Niemann-Pick UK and other Niemann-Pick charities globally got together to form INPDR, which is an international disease registry for Niemann-Pick diseases. This is a global initiative. It was funded initially by the EU and is a patient-held registry. And so what all of the clinicians prescribing these three drugs are being encouraged to do is to basically enter the data on clinical outcomes with these three drugs, either alone or in combination, so that the field can gather real-world data and come up with guidelines on how best to utilize these drugs to maximize clinical benefit. So I think we're in an era of hopefully really extending the quality of life and survival of Niemann-Pick patients as we introduce these two new agents. And it's very early days, obviously, because they were only approved a year ago, the new pair of drugs. But I think we're in a really interesting era now where we can start seeing when we should introduce these drugs, how best to combine them. And of course, probably early intervention will be key. So again, having newborn screening for Niemann-Pick C, I think would be a really advantageous thing to do. So I just want to finish by thanking funders and the members of my lab and collaborators.
Moving on now to this evening's final speaker, Dr. Julien Baruteau, who is UK Principal Investigator for OTC Hope.
I would like to really share with you the experience of having a new baby who has been treated with a novel gene therapy technology for a liver genetic disease and discuss with you this story. And I would like to thank in advance my fellow speakers who have introduced in some ways this topic earlier on. So this is a child who made the headlines earlier this year due to his successful outcome in this gene therapy clinical trial, the phase 1/2 trial. So the problem is that we have more than 150 liver genetic diseases, usually starting early in the life of the patient. And many of them are severe and do not have treatment enabling good quality of life. And for some of them, liver transplantation is really the standard of care or the main option. And unfortunately for babies who really have the most severe presentation most of the time, the gene therapy with the conventional usual viral-derived vectors is not suitable for them and does not allow a long-term correction of the disease. And this is because the most common viral vectors used for liver applications, the gene which is brought back by the viral vectors by the modified virus used as a gene therapy vector, this gene is not integrated in the chromosomes. So that means that during cell division, during the growing of the organ in dividing cells, this copy will not be transmitted in new cells. And that means that overall your effect will be diluted rapidly over time, especially in a rapidly growing liver like the one we see in babies and young children. So there is I would like to show you a new approach which has been developed with what we call gene editing or gene insertion, in which the gene will be directly inserted at a specific location, safe location in the chromosomes, which then enable this safe copy of the gene to be passed to new cells and to enable a long-term correction of the disease. So there are different ways of doing gene therapy, different technologies. One on the right side is to use messenger RNA. This is small transient expression of nucleic acids, which enable the synthesis of a protein, but which has a short half-life and will be degraded quite quickly. So in that approach, we managed to treat effectively some diseases, especially liver genetic diseases, but we need to re-inject this messenger RNA on a very regular basis. The gene addition principle is what I was just referring to in the previous slide, using a viral vector system which will be bringing a safe copy of the gene which is affected in the disease of interest, but this gene will not be inserted in the chromosomes and will not be suitable for a long-term correction of the disease in young children. Another aspect is base editing, which is a gene editing technology which enables to effectively correct a missense mutation. So that means a misspelling of a single base pair long term. So that's enabling a long-term correction, but this is a system which is very specific to a single mutation. And in some rare diseases where we have multiple private mutations, for example, 300, 400 mutations in one condition, this means that we need to have a new system which is optimized, individually designed for every single patient. The approach I would like to discuss with you is a gene integration approach in which the whole gene is inserted in the chromosomes. So that's enable a long-term correction even in young children, and this is that could potentially cure all mutations which are being seen in a specific genetic disease. So this is a schematic of the metabolism in general. This is a busy slide, and I would like to discuss more about the urea cycle, which was introduced earlier on by Jonathan. So the urea cycle is an essential metabolic pathway in the liver, which enables the synthesis of urea in detoxifying ammonia, which is a highly neurotoxic compound, which is produced by the breakdown of proteins. So if we have a urea cycle which is not functioning, we'll have a buildup of ammonia, this neurotoxic compound, and reduced urea production. This is a very severe potential condition when we have this urea cycle defect, because patients will be building up ammonia levels early on. Usually it can be as early as the first days of life, and these patients needs to be diagnosed early, to be treated early, so that we can then retrieve them in intensive care units. The patients can have their blood filtered to remove the ammonia and restore life-compatible ammonia levels. If the disease is not recognized early on, this can lead to severe neurological sequelae, and you can see on the left a brain MRI where you see increased size of the ventricles in the brain, which is in fact a translation of the severe cerebral atrophy that you can see. And on the right side, a post-mortem brain where you can see as well the dilated ventricles, so ventriculomegaly as well, severe cerebral atrophy, and you can even see some cystic formation inside the brain parenchyma. The standard of care therapy for these conditions is usually a combination between a protein-restricted diet, as protein is driving the synthesis of ammonia. We tend to restrict to minimal level of proteins, so patients can have enough proteins to grow and have a protein turnover which is done in an efficient way, but not too much, so that we don't drive excess of ammonia production. The other important aspect is to give some drugs which are to be taken several times a day to reduce ammonia levels. And when this combination of diet and treatment doesn't work effectively, in that case, liver transplantation will be an option. So the main urea cycle disorder, the most frequent one, is called ornithine transcarbamylase deficiency, or OTC. This is a disease where there is around 10 to 12 new patients diagnosed per year with this condition. And this is an X-linked disorder, meaning that boys will be more severely affected than girls. You have different type of presentation, but the most severe presentation can be in a neonatal onset in the first days of life. And in that presentation that you can see on the survival curve on the right in purple, you can see that during the first week of life, half of the patients are dying. So that's a very, very severe condition. And the life expectancy in this neonatal onset condition without liver transplantation is usually around 10% by the end of the first decade. So the technology which has been developed by a company called IOCure is based on two different viral vectors. One which will be coding, which will be bringing the therapeutic gene, in the OTC gene, and another one which will be coding for what we call a nuclease, which is an enzyme which will be cutting at a very specific location in the genome, a safe location, so that the therapeutic gene, this OTC gene, can be inserted in that space. You can see that on the cartoon on the right hand side. You can see the nuclease cutting in orange, and you can see then this therapeutic gene being inserted at the right place in the genome. And the viral vector is engineered to specifically target where the liver cells, where the urea cycle is effectively deficient. So the objective of this phase 1/2 clinical trial is to assess whether this gene therapy technology is safe and whether this can bring a long-term correction of the disease. So this clinical trial is called OTC HOPE. This is a phase 1/2 clinical trial for the most severe form of this OTC deficiency. So that's newborn males will be presenting with neonatal onset disease. So patients who will be presenting in the first week of life with high ammonia levels. So the patients that was treated in our hospital was presenting at day 6 of life with very high ammonia levels, for which he was admitted in intensive care, had this blood filtration to restore low ammonia levels, and was treated with this ammonia lowering drugs and this protein restricted diet. Despite this treatment, he presented another decompensation of with high ammonia levels at the age of 3 months, and then he received gene therapy with an intravenous infusion at the age of 6 months. Then a month later, he presented with an adverse effect of this infusion of gene therapy, with some inflammation of the liver, which was treated efficiently with some immunosuppressive drugs. And then rapidly afterwards were able to first stop the medications and then stop the diets. And this child has been off medications now for more than a year, and has not been having any further high ammonia levels. So he had a complete clinical response. This is showing you the levels of ammonia, which have been going down. So you can see before the treatment in the white box when the patient is on diet and medications, and after the treatment when the patient has been off treatment. And you can see that off diet and off ammonia drugs. And you can see that we managed to decrease the ammonia levels by 2 roughly. And same for urea, we had more than a double of the levels, really showing you that the flux through the urea cycle was much improved. This is a schematic showing how the ammonia lowering drug was gradually reduced over a course of around 4 to 5 weeks, with several steps, being really careful. And on the right side, how the protein intake was gradually liberalized, so this child could now eat a normal diet with no protein restriction. This is just a comment about the fact that it has been a huge logistical endeavor for the hospital. So many different departments of the hospital have been involved. And for example, on the day of dosing with the gene therapy, we had multiple staff who were involved, more than 20 people to make this infusion successful. So to conclude, this is the first child who has been treated with this type of technology. And in fact, we were able to see an efficacy which was very similar to what we see with the liver transplantation, but after a 2 hours infusion. So really a great outcome. And this is opening new opportunities for babies with severe liver genetic diseases. Of course, this is the first patient who has been treated in this clinical trial, so this needs confirmation to see whether this will be with the similar outcome will be seen with other patients. Just giving you to finish the testimony of the parents of the child. Taking part in the trial gave us hope during a very difficult time. At the beginning, we were told that the only possible option would be a liver transplant, and that was devastating. But then miraculously so this child was able to receive gene therapy, and everything changed. Thanks to this treatment, he no longer needs a transplant. His ammonia levels are now stable and he can eat normally again, still with a cautious diet, but without the strict limitations we once faced. For us, this is already a huge step and something we are deeply grateful for. I would like to thank the company who has been really sponsoring this trial, all the team in our hospital and colleagues, and thanking, of course, this patient, his family, and you for listening.
How long will it take? Are there more children in the pipeline for this gene therapy? Or are you waiting longer to see the outcome with this child before you do another one? What's the process there?
So there have been other children dosed in this clinical trial so far, which haven't been publicly, disclosed in terms of outcome yet, but that will happen. We have had other children dosed in our hospital, for example, and in other centers worldwide as well.
Well, I shall look forward to seeing it in press, I hope, before too long. So I'm going to go now to the audience questions. We've got quite a few, so I'll try and rattle through them. So Russell Donis, who's asked a few questions, but we'll go with this one first, which is for Jonathan. I wonder if you know, with the newborn screening of those 7 inherited metabolic diseases, how they are selected, since there are around 2,000 in IMDs. Is it because they're the most common ones? So what do you know, Jonathan, about the selection process at Genomics England?
Yeah, so it's the UK National Screening Committee. They do an evidence review, so they use an internationally recognised criteria whereby they weigh the benefits and harm of screening. And they look to factors such as, is it a important health problem? Is the natural history for that condition understood? and then if there are primary interventions available. So, for example, if there is a treatment available, so if that early intervention can be put into place with the newborn screening, are they then able to be treated as well? So recommendations are research based. So high quality evidence needs to be submitted to the UK NSC during their time, which is basically they used to do an annual call for evidence. Now that's moved to be biannually, so every 2 years, and that can just have like you can either put topics forward for them to review or evidence for conditions to be screened for as well. So I think like moving forward as well. I think in the past, a lot of patients' organisations and other sort of people who would be interacting with this process found it a little bit hard to understand what would be needed for conditions to be added. But recently engaged in a UK NSC conversation whereby they were asking people, how can we make this process easier? How can we get people to engage with it? What do you need from us? So hopefully the process should become a little bit clearer moving forward, so people can really put together that really high quality evidence and get more conditions on that panel. With the introduction of tyrosinemia type 1 onto the panel as well, there's been a new method used to actually add that additional test, and that could potentially open it up for a further expansion as well. So fingers crossed we should see some more. And they are doing another review, I think, at the moment as well for another condition. So fingers crossed we should see it expand, and we will obviously engage with that process moving forward.
Great, thank you, Jonathan. And sorry, I got my screening and sequencing mixed up there.
That's
I was thinking about the newborn sequencing program because I wanted to sort of ask the panel actually because it became in the NHS 10-year health program, the structure of DNA on the front, and they said the ambition there was for every child, to be sequenced at birth. And I wonder what the panel think about that and possible impact for speeding up diagnosis and then therefore potential early treatment of these diseases. Anybody got any comments on that, Jonathan?
I can comment, Sarah, about that because the genomic testing can be taking time because we are testing the genetic mutation in the blood spots, and we then have to go back and test the chemicals, and so it can take a long time. And if there is any variants of uncertain significance, it can cause to interpret that in the clinical context can be quite challenging. So yeah, that's my experience with one or two conditions diagnosed on the genomic sequence at our hospital. Yeah.
Anybody else want to come in? Otherwise, I'll move on because we've got lots of questions now. Jonathan,
Yeah.
go on.
I'll just to say, like, of course, at the moment, I've seen the process whereby the condition was recommended for screening. So tyrosinemia type 1 was recommended by the UK NSC a couple of years ago, and then it was given ministerial sign off, and then took a long, long time to get all of the processes set up, where the information is available for patients and all of the processes have been developed. So when the families get that diagnosis, they know who's being contacted, if they're being signposted to a patient's organisation. So although it would be absolutely amazing to have all of these diagnoses, we need to make sure that the processes are in place for families when they get that diagnosis to access care, support, and to have the correct signposting as well to both organisations and to clinical professionals.
Absolutely, we don't want them just having to resort to Dr. Google until they can, find their feet. So yeah, that's a really big challenge, I think. So we've got another question from Russell Donis for Vidya, who says, aren't many of the red flag features actually non-specific to metabolic disease, and could point to any number of rare diseases? So what's the gold standard for testing when symptoms are not specific?
You're absolutely right. Thank you for that question. So each one of those red flags is not very, in isolation, not specific, but it has to be interpreted in along with, other organ involvement. For example, the cardiomyopathy in MPS disorders is not isolated. It is present along with the short stature, the umbilical hernia, the, enlarged head. So it is the multi-organ involvement, which is probably a red flag for metabolic disorder. So they can have certain eye, signs for for, MPS or any other lysosomal storage disorders like the cherry red spot. So it is in conjunction with another system involvement, which should make us consider metabolic disorder.
Great. Thank you. Does anyone else want to come in on that? I think Vidya's probably answered it quite fully. So the next question is for Evangeline. And someone asks, I wonder what proportion of patients diagnosed with cerebral palsy have undiagnosed metabolic disorders?
I think we don't know the answer to that exactly. I think there have been a few papers out there trying to estimate that, and they've even reported up to 15% of children with cerebral palsy may have an underlying metabolic or even genetic disorder, because a genetic disorder is even harder sometimes to differentiate. I think I mean, of course, I'm a little older, and I remember that children with cerebral palsy, it was only based on clinical exam and history. Now, most children with cerebral palsy get an MRI scan, and I think the MRI scan does give you a good idea if this is cerebral palsy, or if this could be an underlying metabolic or genetic disorder. Then there are still, and I'm a clinician, so at heart and in life, and so there are still things in the history which could highlight a professional to think outside that this is not cerebral palsy. So, and so that is from the history, but also from the clinical exam. So, so there are sometimes clues there that the professional has to look for. And I have to teach others about, I suppose.
Great. Thank you for that. Julien, someone has asked, says the gene therapy you've described is amazing. Is there any risk that the therapy could inadvertently affect the germline genome, or is that not possible?
So this is something which has been carefully looked at in animal models, and there is these AAV vectors, these viral vectors, are not going are not transducing the reproductive cells. So there is no risk that it could be transmitted to the germline and to offspring.
Thanks. And I think a question perhaps for you and Francis, well, for all the panel really. But Francis, and you just mentioned the importance of animal models, both for gene therapy and for drug development. But just yesterday, the UK government announced a strategy that involves moving away from animal models. The small print said phasing out the use of animals in science can only happen where reliable and effective alternative methods can replace them. But the headline message was government vows to phase out animal tests. Do you think this could be bad news for progress in tackling rare diseases?
Yes,
Francis?
I heard that interview yesterday on the radio. So I think it is. I think the devil was in the detail of what was actually said, because when there was a discussion about, are there suitable models? Well, there are suitable alternatives in some settings, but the minute you're trying to look at a multi-morbidity disease in an animal model, or you're looking at a immune infiltrate into a tumor or something in an animal model, you really, when you look at a multi-system disease process, it's incredibly difficult to avoid the use of animals at any stage. And I think in the case of the rare metabolic diseases, we're actually quite fortunate that we've got mutations that are very similar to the human condition that produce a very similar set of symptoms in the mice, and that these have translated therapies to the clinic. So I think that there are two sort of aspects to this. One is that there's also a lot of people will say, well, animal models don't model any disease because we don't have them for some of the common neurodegenerative diseases, for example. But in fact, if you have a model that works, you can do a lot of preclinical work on fairly small animal numbers to get proof of principle. But I think the complexity of whole organism biology is a very, very hard thing to replace. And I don't see that happening personally anytime soon. So that would be my thoughts on it.
Does anyone else want to come in on that? I think Fran's answered it quite fully.
Well,
Nope.
I
Yes,
completely agree.
Julien.
Yeah, I completely agree with what Frances has said. There is now some efforts as well to try to have some umbrella for clinical trials, what we call platforms. And in that case, this is a way to try to reduce, for example, the number of animals to be tested for toxicology studies, for example. So the field is really trying to minimize the use of animals for a long time. We have whole principle to reduce, to try to find alternatives and to design our experimental work the best way to limit as much as possible the use of animal tests. But so these are new alternatives where we can have regulators on board to have effectively one gene therapy technology which could potentially benefit to various diseases. And that way we can effectively at scale reduce the number of animals to be used for effectively moving these different programs forward.
Thank you. So unless anyone else wants to come in, I'm going to move on to the next question, which is for video. It's really a clinical question. So anyone else can chip in if they want to. What are the commonest clinical phenotypes of late Pompe presentations in adults? What would prompt adult care to test for Pompe in adults?
Thank you for that question. I'm a pediatrician, but I'll try my best to answer this question. I can think of our adolescents who presented to us with waddling gait. I can certainly remember an 8-year-old boy with waddling gait. So I guess so the symptoms could be any myopathy. I think we should have a low threshold to test for Pompe. It's a treatable disorder. So testing the creatine kinase and the blood spot enzyme testing, it is quite cost effective. So I would suggest anyone presenting with proximal muscle weakness, any myopathy. So I've had our neuromuscular colleague tell me that she has seen a case of Pompe present in adults with limb girdle muscular dystrophy. So that was a learning for me. So if I come across anyone with that, like you've seen in the pictures, the winging of scapula. So test the CK and the blood spot for enzyme assay for the Pompe. That's what I would recommend.
Great. I could see very vigorous nodding from Jonathan. And I'm going to go to him next with some questions. So one, are you able to support people with MELAS in Switzerland? And then another one with an international bent. They're anonymous, so I don't, could be the same person, who says, that Jonathan, you mentioned that Metabolic Support UK deals with inquiries from other countries in addition to the UK. What's the support like in other countries for people affected by metabolic diseases? What does the international picture look like? It's quite a big question.
It is indeed, but I'll do my best to answer. So, first question, yes. So the best protocol would be to go through our contact form on the website. That will then be handled by our individual support team. So that's the team I mentioned throughout my presentation. So they've got 23 years plus experience of helping people with inherited metabolic disorders. As was also mentioned, we help people in 29 different countries in just the last quarter alone. And moving forward, the inquiries are becoming more and more international. I think that's just as a result of like all of this great awareness that's going on at present. And in terms of the support that is actually available to people around the world, it's very variable. So to give examples, so I lead on our Think Ammonia campaign. So I think this would be a good sort of place to come in with this. So with regards to diagnosing hyperammonemia, and of course the outcomes are really severe, as Julien presented in his presentation, you need to get a really rapid diagnosis. So you need the diagnostic facilities on site. And many countries don't have the facilities available to be able to diagnose hyperammonemia. And as a direct result of that, it leads to worsened outcomes because they haven't got the capability to be able to test for it, which means that they don't know to treat for it, basically. So those people could end up either becoming severely disabled or even dying as a result of these conditions. It's also a case of not being able to access the medications as well. So we recently did a webinar with MetaBRN, so that's the Metabolic European Reference Network, about hyperammonemia. And a lead from Georgia got in touch with me and said that basically they don't have the medication available on hand to be able to treat hyperammonemia, so they don't have those ammonia reducing drugs. So their management solely relies on things like diet and just reducing protein and stuff like that, which isn't really enough to be able to avoid those metabolic crises. So people end up really worse off as well. But increasingly, like as I say, we're doing a lot more work around the world to kind of support that and raise awareness, and also support the development of those diagnostic facilities as well. So um, next month I'll be heading out to Sri Lanka to support a group of clinicians in the country that are looking to set up a patients organisation to support people affected by inherited metabolic disorders, and that will involve basically making a priority for the government to basically address the importance of inherited metabolic disorders. There's a really good group of clinicians out there, really senior consultants coming together and rallying around this because MLK, who was the lead, did this training in Manchester in metabolic disorders and was really like, he really thought, right, this needs to change. We need to make change now. So he's working with me to set this up. So it's although that there isn't quite a lot of there isn't like a lot of support around the world. Um, we are working on it. There are places, of course, where there will be more support, but it is quite variable. So, in your low and middle income countries, there will be a lot less support because, of course, the primary priority is dealing with things like access to clean water and the like maybe the tropical diseases and stuff that they deal with a lot, so malaria and stuff like that. And I think um, the more of the non-communicable disease will become more of a priority as time goes on, and they sort of maybe get those communicable diseases under control, and then they then focus on, okay, what's the other sort of focus that we can do? But there is a lot of good work going on. So I feel like I'm going on into a very long response here,
No,
but there's lots of work going on. So, for example, there's a guy he's a consultant who used to work in the UK, Professor Chris Hendricks. He's based in South Africa, and he upskills a lot of different sub-Saharan African countries and different countries around the world and how to develop patients' organizations. And he's a metabolic consultant as well. So, yeah, it's very diverse, but lots of good work going on. So we should see an improvement in the future.
great. Thanks for that. And it's good to hear that detail and to hear about how it's sort of, cascading around from, clinicians and people like yourself putting in the work. So that's great. So the next question is for you, Fran, from Russell Donis, who says, how many LSDs cause specific symptoms, like in the brain or muscle or specific organs, because those genes are highly expressed in those tissues?
Yeah, I think that, for example, the if we look at the some of the lipid disorders that we've had an interest in over the years, they're very highly expressed, these lipid products, phingolipids, in the brain, and so they tend to be associated with neurodegeneration. But I think for the most part, it's usually a combination of different clinical signs that affect different organs and maybe at different stages of the disease. So you often find that you have different organs affected early on, and then it progresses to involve other cells and tissues. And so it very much depends on the sort of biochemistry and the cell biology of what goes wrong. And so I think it's a sort of constellation of symptoms that often reflect either the levels of expression of those particular metabolites that are in this case accumulating, or it's more complex where there are every cell in the body has those problems, but because of the repertoire of molecules that those cells make, it can have a lesser or a more severe impact. So, and as a general rule, because macrophages tend to store substrates in most of these disorders, you often have an innate immune component, but that's often that's present in all of the neurodegenerative diseases. So I don't think I've really answered your question, but it's very rarely very, very specific, I would say.
Okay, thank you very much. So one for you now, Julien, from Magdalena Dolica, who says, after gene therapy, how long do doctors monitor patients for side effects? I'm guessing as long as they can, really. I think but go on.
So these patients are really followed, lifelong anyway, due to their metabolic condition. In the protocol for this specific trial, the study is lasting for 6 months, and then there is a long-term follow-up study of 14.5 years for a total of 15 years. But it is expected that these patients will anyway be followed afterwards.
Great, thanks for that. That's very clear. And then a question for Evangeline and Vidya from someone who says, do you have any sense of what level of misdiagnosis is occurring? So perhaps Evangeline, you could go first on this. So when patients present, we often hear it's not been mentioned actually the phrase this evening, the diagnostic odyssey of people struggling to get a diagnosis. How often do you think this is happening, or the misdiagnosis is, which is really what the question was about?
I don't think we really know. I think, but I do think it has improved. I think with whole genome sequencing that we have now in the UK, and it's across the world as well, that that we are it's much easier to make a diagnosis. I think so. I do think it has improved, but how many are out there that haven't seen, and haven't had a diagnosis, that is really difficult to know. I know in the UK, for example, every child that has an early death, that gets reviewed quite regularly in several meetings to understand why the children die. So in that sense, it's not something, and in those meetings, it's not listed necessarily as a possibility, or it's kind of that we've kind of missed many of these unexplained metabolic disorders, but I don't know if the data is out there to suggest how many.
And Vidya, I think you'd like to come in on this as well.
Yeah, I agree. It might not be like completely, I agree with Dr. Wassmer, it is getting better, but we're still not there. Sadly, we've had like a few children diagnosed as, for example, we had a male baby with OTC deficiency diagnosed to have some heart problem because the child was quite poorly and developed a heart arrhythmia. And the cardiologists were contacted, and so people were going off in a tangent. And it was not until the cardiac consultant said, have you checked the pneumonia? And then pneumonia was found to be very, sky high. So it can happen. Late diagnosis, rather, I would say, can happen. But we are trying our best to raise awareness with using such a webinars and genomic testing to improve the, to minimize the late diagnosis. Thank you.
Okay, I'll move on to the next question. So this is a question that the person says is for everyone. What is the cost comparison between small molecule versus gene therapy, and which is the best use of limited resources? Don't know who wants to tackle that one first. Julien, do you want to?
That's a good question, as all questions we have had so far. Of course, there is an important discrepancy between the cost of small molecules and gene therapy. The gene therapy is supposed to be a one-off treatment, and so effectively, the injection is particularly expensive. We have some approved drug at the moment which have a cost of around 3-4 million of US dollars for a single injection, for diseases who are supposed to be life-threatening or very debilitating. If we consider the lifetime cost of these children, if we consider the cost of a small molecule, we might be quite costly anyway for a one-year treatment. I think this is something to have in mind. There is a lot of discussion at the moment in the field of gene therapy in general for rare diseases on how to best enable a sustainable financial system to develop more of this costly therapy, because this is costly effectively when we see the figure, but at the same time, this is reflecting years and years of research, of complex research. And when you have, for example, there are some examples where the gene therapy approved drug is not priced at the right value, being underpriced, for example. This is not sustainable anymore for the company, which is now handing back the gene therapy to an academic non-for-profit sector. So there is a lot of discussion, ethical discussion around that, but it's because it's highly priced, it doesn't mean that it's so much more expensive than what it would be with no medications or with a small molecule.
Yes, I would agree with those points that Julien has made. I think it's a very complicated area because we don't have good health economics data on the untreated costs more broadly, both for the affected individual and also the wider family. And I think that with all of these products, we have a sort of a commercial sector that generate these products, and they're looking for return on investment within the period that the drug is marketed or the product is marketed. And then you have a period where things become generics and they should, in theory, get cheaper, but that isn't always the case in the rare disease space. And so it's, I think, a really, really difficult question. And I would agree that the one-off treatments, that if they're very effective and lifelong, that they probably are being, if anything, underpriced because we seem to have a bit of a crisis in the gene therapy sector at the moment, with a lot of companies, who had quite promising products, feeling that they're not commercially viable. So I don't have any answers. Small molecules are not always cheaper because you're giving them year after year. Sorry, I've got a cat just appeared behind me. But I think it's something that really we're in a phase where we're trying to get the most effective treatment to patients of what's available. And for example, in the example I gave, we're talking about combining several expensive products. Again, that's not something that's going to be globally accessible. So when it comes to patient access worldwide, that's another issue. So I don't think we've got any answers. And I think the rare disease space has this really unique pricing model, which is because of the scarcity of the patients. So I think it is a real sort of ethical and moral dilemma.
I just add a little bit to that. I think if you think about a life, say if you did one dose of a treatment and then it sort of ensured that someone wasn't engaging with the healthcare system long term and engaging with multiple services and stuff like that, with the government's focus on reducing waiting times and reducing strain on the systems as well, that might be another important consideration as well, because if people aren't having to access multiple services for quite intensive treatments throughout their entire life, although rare disease might be rare, it's 3.5 million people in the UK affected by rare disease, I think the figure is. So that's a lot of people that aren't going to be engaging with these. Of course, they'll still have to follow treatments and stuff like that, and all that, not treatments, but like engage with this healthcare system to sort of see how they're going and stuff. But it'll completely shift a lot of the population away from the current landscape where they're having to engage in multiple different services and coordinate that care themselves. So I think that could be a good consideration to take into account there too.
Yeah, that's a really important point. Thanks for coming in there, Jonathan. So I was going to ask you to finish the question, which I now can't see. Yes, so this is a question for all, really. What's your view of commercial companies offering MBS panels which include genes outside the current NHS extended list in terms of signposting for families to deal with a positive diagnosis? So I don't know whether you come across this, Vidya.
I haven't come across this, but I can comment on this. So the NBS panel that Genomics England has selected, it was a rigorous process, and all the metabolic and genetic professionals across UK were involved, and they did rigorous scrutiny to carefully select the 200 genes, just so that we will be able to do the clinical interpretation of what we find, to the to give a best possible outcome, and to make sure that we are interpreting in the context of what what we find and what is the practical implication for that baby. So any newborn screening panels done by commercial company, I would be a bit careful, in the sense I would want to know what are included, what are the extra genes that are available. So we have to be a bit careful with that. There are a lot of variants of uncertain significance which can muddle the clinical picture and cause unnecessary parental anxiety. So I think we have to just bear in mind and be careful about that.
I completely agree with that. I think, like from a perspective of NHS as well, it's whether they'll even accept the results, because obviously the NHS labs are all, I think, to be able to test, they'd have to be UCAS accredited. So I think that's a UK accreditation service. So to be able to actually produce those results and to be reliable as well, they need to maintain that rigorous standard. So whether they'd even accept that result from a private provider, I feel like the healthcare team would need to be notified that they were looking to do that, so they could seek some further advice as to best course of action as well, because it might be these families are already struggling financially. So if they're paying out of pocket for private testing, for them to not actually be able to use the result, that can be incredibly frustrating and put further strain on the families too.